Thank you very much. 30 years ago, my wife and I, Helen and I, were living in Nepal in a remote rural district, and since that time most of my research work has been on how to improve maternal newborn health in low-income settings. But I am interested in some of the lessons that we've learned being applied back here for contemporary 21st century problems around ageing, overconsumption, mental health, stress and the like. So in the 90s, we had no idea how to really reduce the kind of 1 in 7 children that were dying in rural Nepal and elsewhere. We did a randomised trial of health education. They obviously need to be told what to do. And so we designed a one-to-one with appropriate health education aids of women in the hospital and in the home in the slums of Kathmandu. And the trial showed absolutely no impact whatsoever on anything, which was a bit of a shock. And then we heard about a project in Bolivia, the Warmi Project, where they had set up groups of women to talk to each other once a month in remote Andean villages, which seemed to be having an impact, but they hadn't evaluated it properly. And they used a community action cycle whereby you come together in meetings and talk about your problems, and then you come up with locally appropriate strategies, you put them into practice, you evaluate together. And it's very much owned by the group themselves, and the facilitators are locally selected. So we decided to do this in quite a remote district of Nepal called Makwanpur. We gave them cameras to give us pictures of their lives, so it was subsistence agriculture, most births were at home. The National Health Service there is largely shamans and traditional birth attendants. And we set up what's called a cluster randomised trial. So the red areas were where we ran a series of women's groups, the blue were control areas, and each area is about 60 square kilometres, and the yellow boundaries, you may say, well, aren't they going to be contamination between areas? But God designed Nepal for cluster randomised trials because the yellow areas are raging rivers and 15,000-foot mountains. So it was good in that sense. And these were the kind of groups that we had, and they talked and they went through the community action cycle. And at the end of the trial, we were a bit staggered to find a really powerful impact, 30%. And we published it in the Lancet, and the silence was deafening. And nobody believed us, and we said, well, luckily we'd set up a few more studies. So we set up another one, a bigger, better trial in the forests of Jharkhand and Orissa in India, and that showed a similar result. So we kind of thought we didn't just get lucky, and it wasn't just noise or chance. This is real. And we even looked at the impact of the time lag, so from setting up the groups until you start to get the life-saving impact is about 9 months, which is kind of socially and biologically plausible. And we then had an even bigger study of 500,000 population in 3 districts of Bangladesh, and the trial showed no impact whatsoever. And so we thought about that, and I told Kishwa Azad, who was our paediatrician there, and I said, maybe Bengali women don't talk like, other women, and she hit me. And then I said, well, maybe they don't network with other villages. And she hit me again. She said, they talk rubbish. Bengali women are the most feisty in the world. And then I said, well, maybe we got the dose wrong. And we looked at it, and because it's very densely populated, the groups per population were more dilute than in India and Nepal. And when we trebled them, that meant we had about the right dose. We repeated the whole trial for another 3 years, courtesy of the big lottery. And fortunately, Ed Fottrell was our epidemiologist. I think he didn't fiddle the figures. And we showed a really big impact, 38% impact on mortality. So we've done a whole series of cluster randomised trials, including in urban Mumbai, where we didn't get an impact because the baseline mortality rates were too low. But we had other effects on domestic violence, and they're now doing some very big studies there on domestic violence. And if you look at, this is a horrible forest plot, don't worry, but the message is that in the trials where we got at least 30% of pregnant women attending our groups, we had a 1/3 reduction in neonatal mortality. Our even bigger effect on maternal mortality, but this was a secondary outcome. And we took it to WHO, who put us through 2 years of misery, and then they came up with an independent recommendation for policy. So we got it into global policy for poor areas, rural populations. And we thought hard about why do groups work, because they're not just about information, they're about all of these issues, building solidarity, reducing stress, sharing information and resources, consumption smoothing, which is where if you're in a village and somebody has a crisis and their income goes down, the others will rally round and help. And the women started to get quite active. It's quite subversive, this, agitating and asking district leaders why services are terrible and why they're not getting their benefits. And we assessed at scale. So bottom left is Arti Ahuja, who's the Secretary of Health for Orissa State, which has 50 million people. And she said, I really like this research, the ECJT team, and she said, I'm scaling this up. And with her budget, she scaled up 140,000 women's groups. So, and now actually the federal government in India has said, we're rolling it out across 8 states. So this is big, and that's worked well. And I should acknowledge that these studies with a whole number of different people and different partnerships, which was great. And recently, we've done another study in Bangladesh looking at diabetes and hypertension outcomes. And we had 3 arms to the study. It's called the D-MAGIC trial. That was my contribution to the study. I like acronyms, you know. So diabetes mellitus action through groups or information. So we had 3 arms: control arm, mobile phone messaging arm, and community mobilization. And I shouldn't be showing you this because it's still under review at Lancet, but I hope it will be published in the next month or 2. Don't tweet that. But astonishingly, the mobile phones had a very small but non-significant effect. The groups had a massive effect on pre-diabetes and diabetes rates, to the extent that no one will believe us again, and we have to replicate it. And at the moment, I'm trying to get funds to try and do it in London and in Yorkshire, actually in Doncaster, which is Ed's constituency. So if we can get that going, I think it's very important to look at it. Now, Robin Dunbar is the cultural anthropologist who talks a lot about the tripling hierarchy of groups and how you have your survival clique, your family, then your sympathy group, and then up to the active network, the Dunbar number, which is the limits of your social brain. You can't manage more than 150 friends. It's your Christmas card list. Anyway, sympathy groups. So we know that we're social animals. You know, we hunt and gather in groups. We do Greek philosophy and innovation in coffee houses in groups. This is the social hospital of Siena in 1440, where on the left you have wet nurses in a group looking after abandoned children. On the right, the hospital committee betrothing one of those children who's grown up at the hospital and is now being reunited into society. You've got women's suffragettes in groups. You have the military, the platoon and sections of platoons in groups. Culture, theatre is classic sympathy group. There may be some theatrical people in the audience. Music, Duke Ellington, film, team sports. 2 of the greatest teams in Europe, Barcelona and Millwall, are both classic sympathy groups. And politics, Ed. Putin has a sympathy group, his own inner circle of the Russian Sistema that Professor Ledeneva writes books about in UCL. And Trump, of course, has 2 sympathy groups, the advisors, and then, of course, the only people he trusts, that's his family. But politics works in that way. So we are social. So why is it that we're obsessed by the individual economy? And in biomedicine, it's all about organs and cells and genes. And we've forgotten the fact that in the 18th century, the professor of medicine in Edinburgh was called the Professor of Medicine and Sympathy. So we've forgotten this, and I've written this book to really say, look, there's a lot of social issues that we need to be looking at for their impact. And I'll give you 3 quick examples. We talked about loneliness. The scale of it is massive in all westernized countries and growing in other countries. It's linked to depression, to people being isolated, and huge costs on social and primary health care. And when I looked into this, unless somebody can tell me I'm wrong, I couldn't find a single randomized controlled trial on how to tackle social isolation. There have been small pilot studies, but nothing at scale to look at how we do this properly and scientifically, which horrified me. especially as we spend 95% of our medical research budgets on treatments and not on this kind of prevention. In Australia, they come up with men sheds to get men to talk to one another, because apparently men can't do that unless they have a tool in their hands. Prisoner rehabilitation, Marina Cantacuzino, sitting in the front row, set up the Forgiveness Project, and they do a lot of restorative justice. On the right there is Peter Wolf, who's a career criminal, and on the left is Tom Riley, the man he attacked when he burgled his home. And there's fantastic stories about how they were reconciled and how Peter realised what impact he was having through his crime and all the rest of it. And he's written a book and all that. But I spoke to him at one of her events and said, what do you think of probation? And he said, well, I came out of Wormwood Scrubs and I, met by a mate and I had some crack cocaine and we went down to Weymouth and we were short money, so we did a burglary within 12 hours. And I said, probation? He said, a waste of time. So anyway, he said, if there had been a group in the hospital, the prison, where there had been maybe some ex-cons helping them with thinking through their future, that might have worked. No studies have really been done on that. Some work in the United States. Adolescence, all your decisions about the way you eat, the way you exercise, your relationships, mental health, smoking, drinking, are all between 10 and 17. At 12, kids stop talking to their parents, you may have noticed, and enter the social edge and are obsessed by their peer groups and mobiles. Again, I can find virtually no good social trials, both quantitative and with social scientists, really looking at ways to intervene. And the psychotic episode that Helen was talking about, 50% of people who have psychotic episodes, and that's 1% of all of us, present before the age of 14. What are we doing to screen and try and intervene early? Final slide, how to create a social ecology for a relational state. I'm not saying that sympathy groups are a panacea, but they're certainly not a placebo. They need a supportive ecology. You can't do this through government edict. You have to create an ecology within which that can happen. As Mark Steers says, you need to create powerful opportunities, empowering opportunities for people by giving them the time, the places they prefer to meet, and the organisation to make it happen. And I would add that science, as academics, we should be evaluating these kinds of large-scale social programs with both quantitative and qualitative evidence, and feeding back this evidence to policymakers like Ed so that they can change the world. If you want to read more, my book will also be on sale at the reception afterwards. Thank you.